V.K. Gupta. Sir, please greet Dr. Maria with the upbeat.
हमको अगली बार हम लड़ाएंगे तो हारना तो कुछ नहीं
अभी आपको पता नहीं है उसमें मेरा बहुत पार्ट रहा है मैंने कहा जो मेरा
Honorary Secretary of IOA, Dr. Sudhir Kapoor, sir, please take your seat on the dais.
अच्छा काम है
तो हम नहीं लेना चाहिए मतलब कभी जाएंगे
संजीव के 2-3 लाख रुपए उड़वाने थे
He'll be greeted with an upbeat as well.
Well, very well for that. डॉक्टर वीके
The President-elect of Indian Orthopedic Association, Dr. Anil Jain, so please, you're welcome on the dais.
अरे कपूर हुए कपूर बड़े हो गए
अरे पूरे हो गए
Vice President of Odisha Orthopedic Association, Dr. Barsa Turu. So you are requested to come to the dais, please.
अनिल कुमार जैन तो उसमें अलग थे हमारे
Honorary Secretary, Odisha Orthopedic Association, Dr. N.C. Mohapatra. You are requested to take your place on the dais, sir. Next we have the convener of the CME, Dr. R.C. Mohanty. Sir, please take your place on the dais. Our joint organizing chairman, Dr. Ashok Viz. Sir, you are requested to come on the dais, please. Dr. Arun Kapoor, coordinator of CME. Please come to the dais. Our organizing secretary, Dr. Sanjay Chaturvedi. I request Dr. Ashok Viz to deliver the welcome address. Mr. President, President-elect, IOA, Dr. Anil Jain, Honorary Secretary, IOA, Dr. Sudhir Kapoor, the Vice President of Odisha Orthopedic Association, Dr. Barsa, Honorary Secretary, Odisha Orthopedic Association, Dr. N.C. Mohapatra, Convener CME, Dr. Mohanty, other dignitaries on and off the dais, esteemed senior members and colleagues, a warm welcome, swagatam, welcome, khush aamdeed to you all on behalf of the organizing team of the Orthopedic Society. Friends, CME is one of the most important academic events of the IOACON, which we always look forward as a delegate. For the conference, it is like jewel in the crown. This year, Odisha Orthopedic Association has organized the CME on decision making in orthopedics, an interesting and engrossing theme, of course. Each one of us must have faced a dilemma of uncertainties of what to do in a particular case sometime or the other. Dr. N.C. Mahapatra and his team have taken pains in choosing the best of topics and faculty to provide solutions and precision in decision making. I am sure we will return enlightened from the CME. We have tried our best to organize the different events efficiently. We do hope we pass your litmus test for satisfaction. Thanking you for your belief in our efforts and a hearty welcome to you all once again. याद मुझे ही कर लेना, आवाज़ मुझे ही दे देना, इस राह मोहब्बत में कोई दरवेश जो मुश्किल है. Thank you. धन्यवाद.
Thank you, Dr. Viz. Now it's time to formally inaugurate the CME. I request the President of Indian Orthopedic Association and other dignitaries on the dais to please come and lighten the lamp. Thank you, everyone. We'll have the formal introduction of the topic of today's CME by Honorary Secretary of Odisha Orthopedic Association, Dr. N.C. Mahapatra now.
Good morning. Respected dignitaries and guests, respected seniors, functionaries and delegates. It's a proud privilege for Odisha Orthopedic Association to organize this CME on your behalf. I hope you will enlist from this CME. So knowledge is power, and it empowers us to take proper decision at a proper time when we face complexities. So keeping this in view, we have selected this topic, decision making in orthopedics. Every day we come across complex problems in our day-to-day practice and we are in dilemma. I hope this CME will help us to tide over this. We have selected important topics from all subspecialties so that this will appeal to a broader audience. I hope you will go in this from this CME. And keeping in view of this green IOACON, we have also brought a small memento from Odisha, which is famous Odisha art that is made in palm leaves, which is totally devoid of any chemicals, colors, and made by handcraft. So I hope you will, and this will be keeping in spirit of this green and eco-friendly conference. I again thank you all for coming to this CME, and I hope you will enjoy this. I thank the local organizers who have been very, very helpful, and I beg apology for any lapses. All the lapses are mine, so I apologize. And I again thank you for coming here.
I request our President of Indian Orthopedic Association to come and share a few words with the audience, and afterwards he will be releasing the CME CD just after his speech.
Honorable teachers, my dear colleagues, and the young future of this organization and orthopedic world. I think this is the most crucial part of the conference, and there are two aspects in a conference. One is learning in the room and the love and oneness generated outside. We are moving well towards this, and I feel that Odisha Orthopedic Association has actually put together a fascinating program. I'm sure we'll all enjoy it, since I so strongly feel that every minute of this is important. I'm going to cut short anything more to say, because the proof will be in the pudding and in the actual academic deliberations. So please enjoy, participate, feel that it is your program. All the best. Thank you.
I request the President to release the CME CD. Our organizing secretary, Dr. Sanjay Chaturvedi, will deliver a vote of thanks now. The CME convener, Dr. R.C. Mohanty, will be sharing a few words with the audience.
President Indian Orthopedic Association, Dr. Maria, Secretary Dr. Jain, delegates, ladies and gentlemen. I, on behalf of the Odisha Orthopedic Association, like to thank the members of the Indian Orthopedic Association for giving us the responsibility to organize the KT Galatia CME program at this 58th annual conference of the IOA. We chose the subject of this decision-making in orthopedics, keeping in view the subjects that were discussed in earlier years. The dilemma faced by the orthopedic surgeons today, while choosing a particular method of treatment out of multiple methods available for a particular condition, we thought decision-making would be a befitting subject. The topics today cover a wide area of orthopedic practice. The subject will be discussed by eminent orthopedic surgeons from all over the country. These lectures will make you think and analyze the different methods and their basis. Our eminent faculty members will share their knowledge and expertise, which I am sure will benefit you. I must thank our co-convener, Dr. Manoranjan Mahapatra, and our energetic Secretary, Dr. Nirmal Mahapatra, and all the members of our team. Last but not the least, my thanks go to our organizing secretary, Dr. Chaturvedi, who he has helped us in answering all our queries and questions complex. I would request you to give your comments suggesting about this CME program at the end of it. Please also give your suggestion regarding next year's subject for the CME. If you find any problems during CME program, please contact Dr. Nirmal Mahapatra. Thank you.
I am privileged to have you all in this hall to start inaugurate CME function. This will be first function for the conference, and I hope that we will deliver what is your expectation. But at times we fail at many things. I know that you will pardon me for that. I thank all the media delegates, the stage president, secretary for helping me out for many things on which I require suggestions. I thank the media persons, I thank the audiovisual persons and all those who are supporting me making this event. Thank you very much.
Thank you, Dr. Chaturvedi. Coming towards the end of the CME inauguration program, I request everyone to stand up for the national anthem, please. जनगण अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा हिंद हिमाचल यमुना गंगा उत्कल जलध तिरंगा तव शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जनगण मंगल नायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे जय. Thank you, everyone. Dr. Arun Kapoor, coordinator of the CME, will now take over.
Orthopedic disorders. I would invite our chairpersons for this session, Dr. Sanjay Das and Dr. S.E.C. Sahu, to the fore. Can you have me there, sir?
Good morning. Welcome to all the delegates. We are going to start the prestigious Cme T1 Ioacon2013. This is organized by Odisha Orthopedic Association and the theme is Decision Making in Orthopedics. The first session is dedicated in topic Decision Making in Pediatric Orthopedic Disorders. We have 4 papers and without any delay, I want to call upon the speakers as we are running 35 minutes late. First speaker is Professor Ranjit Kumar Barua, Professor and Head Department of Orthopedics, Assam Medical College, Dibrugarh. The most popular orthopedic surgeon in northeastern states, has taken keen interest in club feet management and other pediatric problems. Thorough academician from the beginning, he joined in medical college and has presented more than 70 scientific papers and contributed about 16 publications in different journals. His topic will be on club foot and how to manage it. Dr. Barua, please.
Yeah, thank you. Good morning. So I'll be talking on relapse club foot. If we look into the definition of relapse, there is a deteriorate after a period of improvement. Please look into this. Or there is a deterioration in someone's state of health after a temporary improvement. But no definition is taking care of the cure what we're looking at. And therefore, it is important that when you look into the relapse club foot, maybe it's not the complete cure, maybe some residual deformity that has persisted, and those cases being included in the relapse in some of the literature. But with the advent of Ponseti, probably this has been streamlined, and now today we have got some definitions of relapse in CTV in the form of that. It's a relapse is a presentation of one or more components of the deformity on physical examination after correction and maintenance for variable time that's required for the treatment. Now, what is the scope of this topic? I like to highlight on the relapse and commonest form of CTV, that is idiopathic CTV. I have intentionally omitted more difficult CTVs and also elderly relapse beyond 5 years, so that these exclusions became mandatory to provide evidence for a homogeneous group of patients. Now, what is the latest evidence? I looked into the Cochrane Laboratory, PubMed, and also plethora of index journals. What is the Cochrane evidence says that in 2012 that there is no conclusion, no trial defined relapse in their initial protocol, many factors define relapse, making it difficult to report on. And emerging literature, of course, is a good thing of it is that there is a trend of emerging literature attempting to discriminate relapse from mild resistant deformities. Now, relapse can be of multiple deformities, and treatment to correct relapse can be an indication of severity of the deformity. 2 types have been identified, a fixed or passive one and dynamic or residual one. Treatment options depend on the type of the relapse. A well-defined outcome measure of relapse cases will allow the reader to determine the long-term outcome of the initial treatment, which are we yet to see. What's the rate of relapse? The age is maximal relapse could be seen within 2 years, but then it can go up to 4 years. It's very rare up to 7 years. Rate is 10 to 15% reported in different literatures. What's the etiology of the relapse? In 1952, Crispy and Taylor said that the muscle imbalance was the cause because the neuromuscular cause relating to relative weakness of the aortas, and the hypothesis put forward the nerves to the aortas appeared late in the fetus, increased intrauterine pressure on the lateral popliteal nerve, and they said there's no fibrosis. Exactly after 12 years, Gartlin came up, maintaining the same muscle imbalance is one of the causes, but he attributed few other factors like inadequate initial correction, anomalous tendon insertions, abnormality of the talus, so on and so forth. It took almost 40 years to get a clear picture, although semi-clear picture at this point of time. As Ponseti said, the etiology in relapse is the same pathology that initiated the deformity. Clubfoot in otherwise normal children is a developmental anomaly originating after 3rd month of intrauterine life and continued till 3rd to 4th year. In mild cases, late fetal life, and that this developmental deformity appeared in a late fetal life and few months after the birth, and they carried a good prognosis. There is an unknown dysfunction in the posterior and medial aspects of the lower leg, ankle and the foot. Slight decrease in size of the muscles, And this is very important, that there is an excess of collagen synthesis with retracting fibrosis inducing various deformities. Is this relapse rare? Is it rare? It's no. There is a general tendency for the relapse irrespective of mode of treatment. Which feet have tendency for relapse as maintained by Ponseti, stiff, severe and small calf. And this is very important, that the calf feet with very loose ligaments, they tend not to relapse. Recurrence within 1 year, it has been seen that in Ponseti technique, non-compliance in bracing protocol is one of the most important causes, as has been shown by Mortunde from Iowa, 6% with the compliant foot and 80% in non-compliant foot. Late recurrences, of course, there is a limited compliance to the brace, but then some of the factors have sneaking into the etiology, like weak peroneal muscle group, strong tibialis anterior muscle. What are the components of relapse? Hind foot, most important is the equinus and the heel varus, but then it can go up to all the components of the deformity, and all components do not recur to the same degree. How to recognize? This early detection is difficult because it is a gradual onset. During walking, the child tends to put more weight on the outside of the sole of the foot. Looking the child from behind will give us a clue about the hind foot varus. Then one has to look into the passive dorsiflexions, reducibility of talus, heel pad and the calcaneal motion during dorsiflexion. At the same time, we should see the active motion of the dorsiflexion and ability to raise the heel of the lateral foot. Gait analysis is a complicated procedure that has been also come up. Now normally you look into the left side of the picture, it's a normal looking foot, but as the child tries to do the dorsiflexion, there is a supination deformity of the foot. This is called dynamic supination. Prediction can be done because it has got a predictive prognosis. If you can predict that this type of cases will go for relapse, then we will plan the requirement of tendon transfer or avoidance of the braces for long period, those cases where the relapse is not going to happen. Is there the consensus that there is a weakness in the everters, but then there is exact measurements of this weakness is very, very difficult. At present, no predictive way identification. Now there is a small paper published in 2010. They have said that higher pyramid scores, they can be late relapse. Plain X-ray in elderly child, yes, it can be helpful, but in the younger children, probably it's very difficult for yes, positioning and radiation and the appearance of the different nucleic centers. Recurrence do not resolve spontaneously. It's difficult to pinpoint when the relapse occurs fast. Okay, now what is the management in relapse clawfoot? I have gone through this EFORT instructional course in 2012, recommending in the basis of Ponseti. Early recurrence is less than 1 year. Repeat manipulation and casting for 1 to 2 weeks. Retinotomy is dorsiflexion is less than 10 degrees. Tenotomy should preferably be percutaneous. Bracing is an integral part. Elderly children, what is the recommendations? Repeat manipulations and casting for 1 to 2 weeks. Open tear lengthening, short incisions to prevent fibrosis and TAT, vestibular anterior tendon transfer. Dynamic supination is an important part. If we ignore this, probably this patient will go to the fixed type of deformities. It is due to recurrent or residual medialization of the navicular on talus, shifting forefoot medially on the hind foot. There is a relative weakness of the perineum. That should be done, but we should wait till 3 years of age. Now, tibialis anterior transfer, TAT is an integral part of the Ponseti management. What are these indications? Mild recurrences with dynamic supination. Optimum period is 3 to 5 years. It is contraindicated with fixed deformity. Prior to any TAT, recast should be done if the deformity is not fully flexible and talar head not fully reduced. Evaluate dorsiflexion with the knee in extension. This is very important. Aid Achilles tendon lengthening if there is a dorsiflexion is less than 10 degrees. As it was described in 1940 by Gertrude, it was transferred to fifth metatarsal, but and then over a period of time there has been split TAT also. But what is the opinion of Mr. Ponseti is that tibialis anterior should not be split to maintain its eversion power. It should not be transferred to the fifth metatarsal or the cuboid to prevent excessive eversion and severe foot pronation and heel valgus. Different techniques. What is the evidence on fixation technique of the TAT? bioabsorbable interference screws as a single method of fixation, or combination of this along with the button on the sole of the foot, or periosteal scissor that is being followed in the European countries. Now, as looking into the evidence, latest evidence in 2013, that could be found in this very effective procedure to prevent in case of relapse cases, but then this is a short follow-up of 12 months. In various relapses, yes, manipulation and casting and strict bracing program has been advocated, but we should be very careful. Let us look into this paper from the University of Iowa. They have 16 years of follow-up from 1993 to 2009, treated 848 cases, and they had 7.8% relapses, and those cases were treated by TED. Now, what is the conclusion of this paper? This is very important. There is a 15% risk of relapse in those cases. Therefore, they have looked into these cases, and that neuromuscular deficits may be the cause. That has been postulated long back in 1952, still holds good. Muscle biopsy in high index of suspicion cases should be undertaken, and TED may not be definitive treatment for relapse. This point should be put into your mind. Early TED and bony surgery should be avoided, should be delayed as the situation arises. In those cases, cast correction, brace, A for close follow-up is very, very essential. Late recurrences not responding, paucity casting, we have varieties of options. I will not go into details of it. Post-major soft tissue release, yes, it can be done, but it should be a long-hardy procedure, as has been advocated by Ben Sahel in 87. Bony procedures, I will not discuss on this. Elizarov, there have been publications, but then it has got its own disadvantages, long duration of reign, pin track infections, often require revision surgery. Chest is coming up in India, but published reports are few to form an evidence. Devadas et al. In 210 said chest could be done only in elderly children, second-rate tool in early relapse cases. What is the future? The future is genetic and MRI research that is going on actively in Washington University School of Medicine, and they have the aim of their research is to make a classification system and diagnosis so that one can predict a relapse and design individualized care for individual cases. The research on electrical stimulation to improve quantity and quality of the muscle is also going on in the center. But the carry-home message, relapses may occur in well-corrected fit, even it can occur up to the age of 3 to 4 years. Follow-up is very essential, maybe every 2 to 3 months for a period of 1 year, and then every 6 months up to 5 years time, because this is the time where probably foot rapidly grows. As you have gone into several evidences, it is important that we should carefully evaluate these cases. Neuromuscular disimbalance can be a cause in these relapse cases, but then it is very difficult to isolate those cases. Always manipulate and cast for all recurrences, no matter how old. Brace until at least 3 to 4 years. Always manipulate and cast before braces. Either one goes with a repeat tendo Achilles lengthening or tag. Perform TAD in selected cases, not in all cases, after 3 years. Follow-up is the most important, is a tool for detecting relapse as well as taking care of these patients. Thank you for your patient hearing.
Thank you very much, Dr. Barwa. I will request to be seated on the chair on the dais, and question answer will be at the end of the session. I will also request the further speaker, keeping in view that we are 35 minutes late, to try to stick in given time. Thank you very much. We'll call the next speaker, Dr. Mohan.
Our second speaker is Professor Ioacon2013, renowned pediatric orthopedic surgeon, presently Professor and Head, Department of Orthopedic Surgery, KPC Medical College, Jadavpur, Kolkata. Professor Das was working previously as Professor and Head of Orthopedics in the Institute of Child Hair, popularly called the BC Roy Polio and Crippled Children's Hospital, and he has a lot of contribution in orthopedics. particularly pediatric orthopedics, and is most popular orthopedic surgeon in Eastern India. His topic will be, he has contributed publications, a lot of 9 publications in national and international journals, and presented more than 150 scientific papers. Let us listen from him on the topic, developmental dysplasia of hip in late childhood. Dr. Das, please.
Good morning, everybody. First of all, I express my heartiest thanks to the organizer for selecting me as a CME speaker on developmental dysplasia of hip in late childhood. By definition, the developmental dysplasia of hip extends a wide range of pathology from mere acetabular dysplasia, which may not be present before late adolescence or adulthood, to fixed dislocated hip detected at birth. In Western world, the late presentation of developmental dysplasia is not common, but in our country, the developmental dysplasia in late childhood is not uncommon. The reasons are many. There are no existence of screening system in our country, and only a few percentage of newborn babies are assessed for hip instability. So, in most of the cases, they present it whenever they start walking. And even if the detection of developmental dysplasia with dislocation is made, the treatment is not very available in all the centers in our country, because there are very few centers where developmental dysplasia can be treated by surgical means. Now, before going into the details of this subject, we should know what are the pathoanatomy of this condition. There are changes in the acetabulum. The acetabulum is deficient anterolaterally, but posterior or global deficiencies are not uncommon. And it becomes progressively thick, shallow, and oblique with excessive antitorsion. And if you consider the femoral head changes, it is flat posteromedially and deformed, anteverted of varying degree, and coxa valga. And there is also changes in the muscles and soft tissues, which have become shortened and contracted. And with this pathoanatomy, what are the factors preventing reduction? It may be extraarticular, the insinuation of iliopsoas tendon, which may give hourglass configuration to the capsule, and tight adductors. In intraarticular pathologies are constricted capsule, the fibrophatic alveolar, ligamentum teres hypertrophic, and infolded labrum with transverse acetabular hypertrophy. And if there is unilateral dislocation of the hip, it is always worse than the bilateral, because the limb length inequality is there. There is asymmetric motion and strain, the gait disturbances, spine and knee disorders subsequently, and early degenerative changes. And it is always the chronic subluxation produces more symptoms than dislocation proper. And as because the patients are in older age group, so there is no scope of conservative treatment. It should be treated by operative means. What are the aims of operation? To obtain a concentrically reduced and stable hip, to correct acetabular dysplasia, to provide environment for remodeling of femoral head, and to avoid complications such as avascular necrosis of the head of the femur. And if the patient is older than 10 years, the decision to be taken seriously. If the patient presents with bilateral dislocation of hip, then it is to be avoided to do any surgical intervention for these patients. On the contrary, if the patients with unilateral dislocation of the hip, particularly in this patient who presented at the age of 13 years, and he had simultaneously the deformity in the spine, which was operated earlier, and dislocation of the hip, it was unilateral and it was really bothering. So I had to go for surgery at the age of 13 years also. Now, the preoperative traction versus femoral shortening. Nowadays, majority of the orthopedic surgeons, those who are concerned in treating the DDH, they prefer femoral shortening instead of traction, because traction has so many limitations and it is not effective also, and literature also proves it. And what are the treatment options? the treatment options are open reduction and capsulorrhaphy, the femoral shortening, pelvic osteotomy or acetabular augmentation. An open reduction, usually the anterolateral exposure with some modification by bikini incision is preferred because it gives excellent exposure for capsulorrhaphy and pelvic osteotomy. And capsulorrhaphy to be performed carefully to provide more stability following reduction. And the proximal femoral diaphyseal shortening is preferred instead of true subtrochanteric shortening. And if it is unilateral, then it is to be done like this way. But in the case of bilateral dislocation, there should be a spacing of about 2 weeks to 6 weeks, and it is not to be done in same sitting because it is a major surgery. It involves the pelvic surgery, it involves the femoral surgery and as well as open reduction. So for a child aged around 3-4 years, it is really very difficult to tolerate for them if it is to be done at a same sitting on both sides. So the spacing should be 2 to 6 weeks. And acetabular procedures. Usually these acetabular procedures we have to perform the osteotomy of the innominate bone by Salter's technique, and it is the most commonly practiced techniques. It is to be done up to 6 years of age. And acetabuloplasty by Pemberton or Dega. So nowadays the Dega osteotomy is preferred by majority of the pediatric orthopedic surgeon. The osteotomy that free the acetabulum, the still triple innominate osteotomy, lunge acetabulum osteotomy, this is mainly reserved for the patients, those who are around 10 years of age, not before that. The styly operation, self-operation by styly, and innominate osteotomy with medial displacement of the acetabulum, it is also to be done if the patient is around 10 years of age. This is in the schematic diagram of the different types of osteotomy. The Salter osteotomy, there is a rotation following cut which extends from anterior inferior iliac spine to sciatic notch, and it is to be fixed by cable. And in styly osteotomy, there is a gutter is made at the acetabular level and the bone grafts are put there. But this is a modification of Wilkins technique where the grafts are taken from the dorsal aspect and it is everted over the capsule and then anchor suture is made. And Pemberton and Dega osteotomy. In Dega osteotomy, the cut is up to the level of the sciatic notch, but the osteo is intact and the modification is there. And these are the examples of Salter osteotomy. And yes, in this case, this patient presented before me at around 1.5 years of age, and open reduction was carried out. But at the time of operation, it was found the head is grossly distorted. I could not diagnose it. What is the exact diagnosis? Obviously, the operation was failed. It was redone along with Salter osteotomy, even if there is no correct reduction of it. Subsequently, at her age of 8 years, it was found it was a case of multiple exostosis. And this is another example. The patient presented at the age of 9 years, and the Dega technique is used here. If you carefully note, at the level of the acetabulum, there are a series of bone grafts are placed. And this is an example of the acetabular augmentation by Wilkinson, modified Wilkinson technique. And this is Dega's procedure. Here, the patient presented at the age of 7 years with subluxation, and the Dega procedure was done along with femoral shortening and some varus correction was also done. This is the end. And here again, at the age of 3.5 years, the patient presented and she has arthrodeposis multiplex congenital. So all the processes, that means the open reduction, the acetabular procedure, and the femoral shortening was done completely. And before going to the surgery, intraoperative assessment to be done, and after this intraoperative assessment, give the two picture. So at the time of operation, intraoperatively we have to take decision. And regarding this, a paper published by Jade et al. In can be assessed intraoperatively. If it is stable in neutral position, no osteotomy is needed. If it is stable in flexion and abduction, no osteotomy is desired. And if internal rotation and abduction is fixed at internal rotation and abduction, the proximal femoral lateral rotation osteotomy is done. And double diameter acetabulum with anterolateral deficiency Pemberton type of osteotomy to be performed. And it is also associated with lot of complications: the avascular necrosis, redislocation, stiffness, residual dysphagia, and osteoarthritis. Here is the patient. This patient presented at the age of 5 years with bilateral dislocation, and the open reduction was done on the right side first, then left side, and subsequently the patient develops this much of avascular necrosis and the neck shaft angle is vastly diminished. Right. Now, in conclusion, the early diagnosis of VDH is absolute necessity for successful treatment outcome. In our country particularly, the older children presents with VDH are not uncommon. And one-stage procedure consisting of open reduction, femoral shortening, and acetabular procedure yield successful end result. If perfectly done, the remodeling is excellent. All the patients to be followed at regular interval till skeletal maturity, and secondary procedure to be undertaken where it is indicated. Thank you.
Thank you very much, Dr. Das. I will request him to be seated on the dais in the chair. And again, questions and answer will be at last. Thank you very much.
Thank you, Dr. Das. We'll be calling upon another Dr. Das, Dr. Shakti Prasad Das, working as Assistant Professor Orthopedics and Head of PMR Department in SB Nittar, the Government of India Institute at Cuttack, Odisha, where I was working for 32 years. His field of interest is in pediatric orthopedics and locomotor rehabilitation. He has published more than 7 articles in national journals and different state journals also. And besides presenting a lot of scientific papers, Dr. Das will be talking to us on the topic neglected Portis disease. Dr. Shakti Prasad Das, please.
Thank you, sir. Respected Chairman, sir, a very good morning to all of you. Leg Calvé Portis disease, leg Calvé Portis described the disease 100 years back. In 1910, lot of research and publications has been made in etiology, epidemiology, natural history, radiological classification, treatments and outcomes. But still, it is the most controversial subject in the pediatrics orthopedics. And neglected Portis also is a challenge. So what is Portis disease? It is a juvenile form of idiopathic osteonecrosis of the femoral head, which develops in children between 2 to 14 years of age. There are a lot of classifications starting from Cattrall, Salter, Thompson, Harris and Stulberg classifications are in Portis described. But we are proud that our own Dr. Benjamin Joseph and his team from Manipal, they have described a classification which is easy to understand and also reproducible. And their classification goes like this: avascularity, fragmentation, regeneration and complete healing. So what is the pathophysiology? It starts with the idiopathic vascular insufficiency, which leads to necrosis, resorption, collapse, then remodeling and complete healing. So what are the concerns? Concerns in Portis disease are: we want to prevent the deformation of the femoral head, the enlargement of the femoral head, and the capital physeal growth impairment, as well as ultimately to prevent the secondary degenerative arthritis of the hip joint. So to prevent, we want containment. If everything goes fine, case detected in perfect time, in perfect stage, then if containment is done, then congruence is achieved and good range of movement is expected. And that can be achieved by some conservative methods are described, like short tissue release, casting and surgery by varus derotor osteotomy, varus extension osteotomy, Salter's osteotomy, and nowadays greater trochanteric epiphysiodesis has become part of the varus derotation osteotomy. So containment should be done in the early stages. If everything is fine, we expect these results. In Indian context, we want cross-leg sitting and squatting, and everything is fine, then this is the ultimate we expect. But unfortunately, things always does not go with our wish. So the children present with more age or epiphyseal involvement is more, and evolution of the disease in advanced stages, or epiphyseal extrusion is more, or restriction in hip range of motion, then problem comes and outcome is also poor. So probably these stages of the disease you do not want to see. If you see this type of stage of disease, then we expect a poor outcome. So once we diagnose or we detect a neglected epilepsy, the treatment is always surgical. So what is the neglected epilepsy disease? Either it is an untreated case or a poorly treated case, or if age of onset after 8 years of age. These type of cases also behave like neglected epilepsy and all the complications. Here is a X-ray which shows that the operation has been done, varus derotation osteotomy is done, good containment, but see the coxa vara. So if it is poorly treated also, they are neglected and they lead to trochanteric overgrowth and Trendelenburg gait. So there are a lot of studies which show that if the disease onset is at the adolescent also, their results are poor. So what are how these cases present? These cases present either coxa magna, coxa irregularis or coxa brevis. Coxa magna and coxa irregularis, they go for secondary degenerative arthritis. But coxa brevis, in which there is short neck and trochanteric overgrowth, they go for Trendelenburg's gait. These are the X-rays we show that neglected epilepsy in various stages. So the treatment options are either starting from pelvic osteotomy to total hip replacement. We will discuss one by one. And there is suppose you are in OPD, you can diagnose by a short classification also, pre-collapse, collapse but not ossified, collapse and ossified, remodel and degenerative. If that classification can be done by X-ray, arthrography, 3D CT, MRI, then we can take also a decision in the outdoor BG outdoor. So if it is pre-collapse, then containment can be done with medical management like bisphosphonates and anabolic steroids. And if post-collapse not ossified, then soft tissue release, hip joint distraction, all these methods can be tried. If ossified, then valgus osteotomy and femoral head reshaping. If the disease is remodeled, degenerative, we know there is no option than arthrodesis and joint replacement. So what are the aims? The aims is, if the head is irregular, shape and size is not perfect, then pelvic osteotomy will solve our purpose. If a hinge abduction, then valgus osteotomy. Hinge abduction is there is anterolateral bump or new bone or anterolateral overgrowth of the epiphyseal junction, which does not allow the head to go inside, ultimately hitting on the supraacetabular rim and causing decreased abduction as well as pain. And to treat the trochanteric overgrowth and coxa brevis, trochanteric advancement are the choice. So Salter's osteotomy is some surgeons do Salter osteotomy as a primary procedure also in Perthes disease. So it is a transverse osteotomy which just above the acetabulum from anteroinferior iliac spine to greater sciatic nerves, and the lower fragment is anterolateral displaced, graft is given and fixed. So this is a case where there is uncovering and treated by the Salter's osteotomy. Cme osteotomy is used when no other osteotomy is possible. So this is cut from the anteroiliac spine to the nerves following the capsular crop, and distal fragment is displaced medially and fixed. So that behaves as a acetabulum. So this is a case where the Cme osteotomy has been done. Self-acetabuloplasty or Stahel's surgery, it is advised in non-concentric hips. It augments the superolateral deficiency. There is a 1 centimeter deep trough is made on the supraacetabular rim, and outer iliac strips taken from the iliac crest, which are fixed in layers and bone graft given, and this is stabilized by the rectus femoris muscle. So this is a case which presented to us very late. So you can see the advanced stage and epiphyseal has been extruded. We have done a self-acetabulopathy procedure with the trochanteric epiphysiodesis, and ultimately the child is able to sit cross-legged and squat. So articulated hip distraction. This is a procedure advised when the head is not collapsed but not ossified. So at that time, if you distract, some space is created, ultimately the head will get some area to grow, and congruence will be maintained. That is the aim of this articulated hip distraction procedure. So we have done some cases with encouraging results. Trochanteric advance done in when there is healed, no pain, coxa breva with trochanteric overgrowth. So trochanteric overgrowth leads to Trendelenburg gait. So this procedure is done in the in supine position with that in the image intensifier facility, the red arrow shows the trochanteric overgrowth. So, this trochanteric growth is excised in line with the neck of the hip femur and distalized and fixed by 2 screws. Ultimately, our results are fixed. And then valgus osteotomy. We have already discussed the hinge abduction method. Hinge abduction osteotomy. That is also this is due to when there is no growth is in the anterolateral part of the head. The head cannot go inside. By doing this osteotomy, the head able to go inside the acetabulum. That is the principle of valgus osteotomy. So one case where valgus osteotomy has been done. So triple pelvic osteotomy and periacetabular osteotomy. These two osteotomies are technically demanding procedures. It is either is iliac, super iliac cut like salters, and another 2 cuts in the iliopubic rami and ischiopubic rami, and now the acetabulum after the osteotomy is free, so we can direct the acetabulum where we want to cover the head of the femur. So these are the, no doubt, it is a very, very difficult procedure to learn, and some people also do this surgery. Those who think that varus zero osteotomy gives rise to limb and short limb, they also advocate this type of procedures. So periacetabular osteotomy has been done. So then you call Mercer's osteotomy. Mercer's, E.W. Mercer described in 1980. This is known as also neck lengthening operation. This is advised in some of the complications of septic arthritis as well as the old DDH patients also. So in this case, 2 osteotomies are made. One at the base of the trochanter, parallel to the neck superiorly, another to the neck inferiorly, and trochanter is distalized and fixed. So this type of procedure ultimately we get the result which corrects anatomically and biomechanically is the hip joint. Skelectomy, this procedure is again same bump which is anterolaterally created, is excised, and this is done by anterolateral approach which described also previously it has been described. The results are also good. Coxa magna and coxa irregularis, they are treated by osteochondroplasty for impingement or Ganz reduction osteotomy. Osteochondroplasty is the procedure, I think colectomy and osteochondroplasty surgically both are synonymous to each other. Similar type of procedures, it improves the head and neck offset and helps to the head of the femur to go inside. And these methods can be done by open methods, arthroscopy method, or by the safe surgical dislocation method described by Ganz. So these are the procedures in a 10 years boy of osteochondroplasty in Perthes disease. Ganz reduction osteotomy, after the safe surgical procedures, now we are able to dislocate the head. So aspherical coxa magna, spherical head can be made spherical by the dislocation method. So the head, these are the pictorial presentation. After the trochanteric osteotomy, the lateral part of the neck is cut and is vascularity is maintained, middle portion is detached, then the superior part, inferior part fixed to each other. So by this method, a aspherical head can be made spherical. So these are the surgical steps of the Ganz reduction osteotomy, means head is reduced. So when there is pain, irregular femoral head and hip joint is not congruent and arthritic changes, there is no other option than the arthrodesis. And as all of you know, the ultimate, when there is nothing is possible, painful, arthritic changes, there is total hip replacement with us. I thank my, I have taken advice from these fellows, Dr. Hitesh Sir, Dr. Benjamin Joseph, Dr. Bhusa Madhuri and Dr. Ashok Jori. Thank you, sir, and thank you for your patient hearing. Thank you.
Thank you very much, Dr. S.P. Das. Please be seated on the dais. We call the next speaker.
We are going to be the last speaker of this session, Dr. Ashok N. Johari, the most popular and stalwart pediatric orthopedic surgeon in India. He is from Children Orthopedic Center, Mumbai, and he needs very little introduction as all of us know him very well. He was the former president of IOA and was also the past president of Asia Pacific Orthopedic Association, Indian Academy of Cerebral Palsy, and he is also the immediate past president of CCOT, the international conference of CCOT which was held in Hyderabad in October 2013 was done very successfully under his leadership. He has a lot of publication and contribution in the field of pediatric orthopedics. He has delivered hundreds of scientific publications and scientific papers and publications in journals. And his deliberation today will be on sequel of neonatal septic arthritis of hips. Dr. Johari, please.
Thank you, Chairman, sir. Senior colleagues and friends. I'm going to be speaking on a problem which is fairly well seen in the developing part of the world, that is septic arthritis of the hip, and we often see sequelae. The results for sequelae, why sequelae occur, is because of delays in diagnosis. So when you have delay in diagnosis, you have sequelae. Residual disability often affects the hip joint, largely in terms of proportions. 43% of the residual problems affect the hip, 33% the shoulder, 15% the ankle, and 8% the knee. Why is hip joint sepsis commonly missed? Because it's a deep-seated joint. It is difficult to examine and aspirate. The localizing signs are poor. There is presence of intercurrent problems. There are many other problems in a neonate and multiple involvement, so that one area or one affection is missed. You may catch a shoulder problem or a knee problem, but miss the hip joint problem. Now we described the sequelae affecting the neonatal hip in 1988, and we formed 5 groups. In group 1 and group 2, the femoral head is absent. Group 3, 4 and 5, the femoral head is present. We realized long ago that each group is very, very distinct in its behavior, and the management protocols for each group are different. Now group 1 is a situation where you have a stable joint because of the presence of some part of the metaphysis inside the acetabulum. Group 2, you have an excision arthroplasty effect, a totally unstable hip. Group 3A and 3B are dislocations and subluxations. Group 4 is a Perthes-like group. Because of avascular necrosis, you have problems, coxa vara, coxa breva, coxa magna, etc. form this particular group. And group 5 is pseudarthrosis of the femoral neck. Now, because of constraints of time, I am going to focus on the situation where the femoral head is absent, and these are group 1 and group 2. And how do we make decisions in this group? Now, the first problem we are faced with is whether the femoral epiphysis is present. What is the status of the capital femoral epiphysis in this patient presenting at 1 month with this sort of a osteomyelitis picture? Well, she came late. We operated on her. There was pus. The femoral head was separate. We pinned the femoral head and matter stood there. This is a couple of months later.